Alrighty, we are going to go ahead and get started. I would like to introduce myself first. My name is Kayla Franklin. I am a health education coordinator with the Southcentral Alaska HACC, the Area Health Education Center. I am joined today by my colleague, Naya Boney, who will be helping organize this and keeping an eye on that chat box. So thank you and happy birthday to Naya Boney as well. Today is her birthday, so very exciting. I mentioned this previously. This is our list of the Brown Bag series. Today we will be discussing cultural competency, and I am very excited to be able to share this content with you. If you have any questions or comments that you would like to share throughout the presentation, please feel free. There is a chat box where you can go ahead and do that. Hi everyone, welcome. People are still trickling in. All right, so I am going to turn off my my webcam. I wanted to have it on to introduce myself, but I'm going to go ahead and turn that off. All right, so a brief overview of Southcentral HACC. We are a team promoting health workforce development so all Alaskans have access to employment and quality health care. We are hosted by the Alaska Primary Care Association with the goal to create healthy communities in Alaska through the support of vibrant and effective community health centers. All right. A few of the Southcentral HACC programs that we provide are health career camps for youth and high school students who are interested in exploring health-related topics and professions. We also host 3-week PATH academies to provide professionalism training for adults interested in health. We support students who are enrolled in health courses, as well as continuing education for current health professionals. For those of you who are new to GoTo training, you can see here a few of the icons that you see on your screen. You have the audio with muted and unmuted. At the moment, everyone should be muted, but you can unmute yourself. You can also indicate a raised hand with this hand icon to show that you may have any questions or comments. And furthermore, if you do have questions or comments, you can enter those in the chat box option. You can send it either directly to me or another organizer, or you can send it to the group as a whole. And then materials and audio settings are also there. All right. All right, so without further ado, let's go ahead and dive into cultural competency in healthcare and why it is so important. So what is culture? Culture is formed when a group of people share the same values that establish expectations for behaviors. It's important to recognize that every individual is multicultural, meaning we all identify with multiple cultural groups simultaneously. Diversity is much bigger than just racial and ethnic background, and it has the power to shape our language, behaviors, and institutions, especially healthcare institutions, and those interactions that providers have with patients. And as a healthcare provider, one must be able to work with patients who come from diverse backgrounds, family members who are diverse, as well as working with diverse staff members and other providers. I'd like to note here that one person cannot speak for an entire cultural group. We all belong to multiple groups simultaneously, as I mentioned, and these include genders, ethnicity, age group, religious affiliation, sexual orientation, education. And that being said, these all hold their own values and norms. When these values conflict with one another, we choose which to uphold and which to ignore, thus expressing culture in a unique way that may not be indicative of the whole group. So Alaska is an incredibly diverse state. In Anchorage, we have over 100 languages that are spoken, and at least 20 of those are native to Alaska. Mountain View in Anchorage was named the most diverse neighborhood in the United States in 2016. We also have the top 2 most diverse high schools in the United States. Furthermore, a great deal of historical trauma experienced by Alaska Native populations is a root of many social, mental, and physical health issues faced by families and individuals to this day. Epidemics decimated populations, children were forcibly removed from their homes and placed in government orphanages and boarding schools where severe abuse took place. And because of this trauma and abuse, many institutions, particularly healthcare institutions, may be viewed with a high level of distrust and discomfort. Because we live in such a diverse state, there are so many different worldviews that bring values to the table. And these worldviews also affect one's understanding of what causes illness and then what restores health. And Western cultures often lack a holistic perspective and may not consider outside elements that others see as an important factor to health and well-being. So defining cultural competency. Cultural competency is the ability for individuals and organizations to work together in cross-cultural situations using effective communication. Delivering appropriate care that is mindful of cultural influence has been recognized to improve the quality of care and increase patient safety. This includes increasing our awareness of ourselves and our communities. Because we all identify with various cultural groups, these are constantly shifting and shaping our values. And as we increase our awareness of those values, we can also become aware of those around us. And the overall goal of cultural, competent, and compassionate care is to improve patients' quality of care, access to care, and having positive outcomes in the present and future. So why is cultural competency so important? As I mentioned, it does improve the quality of care, which is our ultimate goal as providers and health centers. And in care settings, language and cultural barriers may result in misunderstanding and a lack of compliance. Patients may not understand the care practices that are being put in place for their health. They may not understand or be hesitant to take medications. Because of this, negative health outcomes may result and lead to a lack of trust in healthcare institutions and providers. This can kind of domino effect into decreased patient safety, satisfaction, and reimbursement, leading to negative health outcomes altogether. So I'd like to discuss a few contributing factors. One is ethnocentrism. This is the belief that your way of life and worldview are superior and better than others. Ethnocentrism has been a historical driving factor in assimilation efforts. One example of this would be the Holocaust in World War II. Another contributing factor is essentialism, which defines groups as being essentially different, giving groups characteristics that are deemed natural to that group. And this doesn't allow for any variation or any changes within this group. So an example of essentialism would be, I am a millennial and I have a lot of people in my life who are from different generations who expect that I can fix anything technology related. Unfortunately, although I am not technology illiterate, I am not particularly strong in the topic of technology. And that is a misconception, I think, of many millennials, as I can relate to the struggles of technology as much as anyone else. So essentialism can lead to stereotyping patients and assumptions that are based off of limited information. And then power differences. These reflect the power imbalance between a patient and provider in their relationship. Those who have power are often not aware that they have the power in the first place, or if they are aware, they may not be aware that it has negative effects on the patient daily. Without knowing about these power differences and being aware of these negative effects, we can perpetuate disparities in healthcare. So in terms of contributing factors, awareness of one's own values and those of the healthcare system is the foundation for culturally competent care. Ethnocentrism, essentialism, and power differences may affect one's ability to provide appropriate care to their patients. And these beliefs may or may not be conscious. Someone may be very aware that they have values that are put in place by cultural influences and therefore may be aware of their interactions with others based on those values. However, some of these beliefs may not be conscious. They may not be aware. All right, so I have 2 case studies here for you. All right, we got the muted stuff figured out. Awesome, great, thank you, Nayaboni. So I'm going to go ahead and read through 2 case studies, and afterwards I would like to allow you some time for some reflection. You can either take some, notes on your own, or you can contribute through the chat box. I would love to hear some of your input. So I'll go ahead and read this first one, and then I will have a reflection question for you at the end. All right, number 1. You are a community health aide working in the clinic of the village where you have lived your whole life. A new staff worker, a nurse practitioner from Kentucky who will be working here for the next 3 months, is shadowing you for her first shift. You have just called back the first patient, an elderly gentleman complaining of a headache. You greet your patient in the native language and inquire about his family and his home, and ask his opinion about whether he thinks the upcoming fishing season will provide enough to last the winter. The NP cuts in and urges that she needs to begin the examination or other patients will be kept waiting. She does not introduce herself and begins asking many questions about the patient's symptoms without waiting to hear his full answers. After only a few minutes, she determines he just needs to drink more water and gives him these instructions. The patient listens, then exits the room without any further comment. After he has left, the NP expresses that she is offended. He neither thanked her nor said goodbye. You know this was a poor experience for the patient and are concerned others will feel the same way with the new NP. All right, so I'm going to give you all a few minutes to reflect on this case study. And my question for you is, have you ever had a similar experience either as a provider or as a patient? And if you have, what emotions and challenges did that elicit? So I'll give you a few minutes. Yes, thank you, Gail. Yes, absolutely. An overall negative feeling of care and concern. Absolutely. Never return to the practice again. Definitely. Awesome, thank you. I'll give you all a couple more minutes. Oh, yes, absolutely. We can definitely unmute if anyone would like to. Yes, everyone does have the option to unmute themselves if you would like to do so and speak up about a particular experience you've had. All righty. Thank you all for your responses. I have one more case study for you. And I will go ahead and do the same thing. I'll read this out loud and then have a question for you at the end for reflection. All right, case study number 2. You are an RN working in the labor and delivery unit at Providence Hospital. One of the patients that has just arrived in the early stages of labor. Oh, was someone trying to speak up? No? Okay. All right. This is her first child and she is only at 34 weeks, so it is a little early for the baby to be coming. The patient is in distress because the hospital staff is not doing any of the things her mother taught her were necessary when a woman has a baby. She has not received the special herbal tea that helps a woman have strength for delivery. She has not been told she has been told she cannot save the placenta once the baby is born, which she believes must be buried in the earth in order to protect her baby against bad spirits. And the available physician who has been called to her case is a male who needs to examine her, but she is refusing because it is forbidden for any man except her husband to see her unclothed. Finally, everyone keeps telling her that her son will be transferred to the NICU immediately after delivery. But she knows any son who does not spend the first 24 hours of his life beside his mother will never find a wife. Labor is progressing quickly and you are worried for the patient and her baby. What would you do in this scenario to demonstrate professionalism, emotional intelligence, and cultural sensitivity to aid this woman to a safe and successful delivery? All right, I will go ahead and give you some more time to reflect on this. And like I said earlier, please feel free to unmute yourself and contribute to the conversation, or you can provide a chat in the chat box. Stephanie, that is a great point.
Kayla, this is Mari. Can I read some of the comments that I hear?
Yes, please.
Okay, so Stephanie's saying it's also important to understand that in a rural and village setting, people don't always have a lot of choice in providers or institutions. A negative experience may mean not seeking healthcare. I think that's an excellent point. It's also important to realize the historical context of institutions. What we know as IHS today has roots in what was the War Department because Indigenous people were considered prisoners of war. And Stephanie, if you wanted to unmute and contribute more to what you were saying, please feel free.
Sure. I think it's important to realize that for lots of people, your family or your friend's experience is truth beyond something that comes from an outside source. But for Indigenous people or any culture that's been experiencing long-term negative experiences from an institution, that institution becomes a default distrust thing. So in my lifetime, I haven't had a ton of terrible experiences with IHS, but my dad did, his parents did, his grandparents did. And so every time I have an interaction with a medical provider, I have to negotiate the family truth that is really close to me and what's going on right now. And as humans, I mean, one of the things that we do is try to avoid negative experiences. So when you have a heritage of negative experiences, it makes it very hard to trust an outside source. And if you have a negative experience of your own on top of that legacy of negative experiences, that becomes a very strong truth to you and a very, very much part of your reality.
Absolutely. Thank you so much, Stephanie.
Sierra also pointed out that her dad's nurse was frustrated because he wasn't understanding his care plan, which was life-altering, and she yelled at him, shook him in hopes that he'd understand. And he was confused and scared, and after being diagnosed with cancer, sounds like she reported this nurse to the Board of Nursing because he almost had to go to the ER from this outburst. So that sounds like that must have been a pretty traumatic experience for family.
Yes, absolutely.
And finally, Dawn, there's other comments on here, but Dawn in Bethel mentions that there's an elder board member that rarely contributed to the conversation, and it was because we went too fast. So it sounds like the clinic staff was going too fast. She needed time to collect and present her thoughts.
Awesome. All right.
Thanks, everyone.
Yes, thank you. All right. I do see Sierra said for case study number 2, try to meet in the middle, find a female physician and see if we can find T. That seems like an easy way to calm her concerns. And if she could go into the NICU with the baby, then that would be a great option as well. Yes, thank you so much, Sierra. All right, we will go ahead and move forward. I have a video here for you that portrays an example of cultural compassion within a hospital that provides for a large Hmong community in California. So I'll go ahead and play this clip. One moment.
The Hmong people do not trust the doctor. They'd rather go to see the shaman first.
There was a fear of the hospital, so a lot of times when they would finally come to the hospital, it was at a crisis.
Merced is a small town. We have more than 7,000 Hmong living in Merced County since 1976.
When they first arrived in Merced, of course, they didn't know anything about our culture, and we didn't know anything about theirs. And so there was a challenge to communicate. Hmong shaman will tie strings around the wrist of the person that they are giving a ceremony to. Our staff would cut them off.
The misunderstanding really caused a lot of issue in our community.
We wanted to bring the shaman into the hospital because Dignity Health understands that healing is looking at the person as a whole. It's body, mind, and spirit. So the Hmong shaman are spiritual healers.
So we decided to have this orientation class for the shaman.
We wrote a policy, actually a hospital policy, and it identifies 9 ceremonies in it that the Hmong shaman can come into the hospital to do for the patient.
We not just teach the shaman, but we do teach the resident physician to learn more about the traditional belief, the spiritual healer, to listen to them to see how they do it, how do they help the patient. I have seen a lot of changes. It really made the Hmong community feel better, open it, and talk about it, because they used to put under the table, don't want to share to anyone.
Cộng lúa thia, mù cận đó lúa thia, để thì bỏ kỳ trả, để cho nhau chạy sự thế chỉ bỏ, cho kỳ trả.
All right. So I know this may not represent the reality of every healthcare setting, but it does show the evolution of a culturally compassionate relationship between a healthcare institution and a subculture in their community. So I'd like to open the floor again one more time to kind of see what people thought of this video. What practices did you see that were culturally compassionate and what changes they made to reach that point? A few comments. Diana says, sharing knowledge helps everyone. It is the only way we grow as people and increase our ability to help each other. Absolutely. I love in this video that they discussed not only teaching the physicians, but also teaching the shamans and vice versa. And at the end, when the shaman mentioned learning from the Western culture as well, definitely creating that, bridging that gap and creating that relationship of knowledge. Absolutely. Thank you. Accepting that there are different ways to heal, absolutely. Sierra says, it's awesome that they didn't just say your way is wrong, but instead said, how can we integrate? Yes, absolutely. Yes, allowing the shaman into the hospital and using the strings. Thank you, Mary Lou, that's a great example. One of the contributing factors that I mentioned earlier was the having issues with power imbalance. And I really love how this video portrays that it was recognized that there was a power imbalance between the hospital and this subculture, and implementing steps to make sure that that was leveled and making allowing both parties to have equal power in the relationship. Yes, instituted the policy, absolutely. Put it in writing, hospital-wide. Awesome. I would like to note that in our AHEC workforce development, we support multiple Hmong students who are pursuing healthcare fields. This means they will be joining the medical and health workforce within the next few years. This is an example of how providers will not only be working with diverse patients, but also with diverse providers as well. And this group of students will have training from a conventional and Western institution, as well as an extensive knowledge and connection with their Hmong culture. So they'll be able to bring a lot to the table. While we're still discussing the Hmong culture, there is a book that I would love to recommend to you all. It's called The Spirit Catches You and You Fall Down. It's written by Anne Fadiman, and it's based on a true story about a patient-provider relationship in a hospital, also in California. The family was part of the Hmong community and had an infant with epilepsy, and the story illustrates the initial challenges that were faced by a lack of understanding, and the steps that they took to mend and strengthen their relationship. So I would highly recommend it. The Spirit Catches You and You Fall Down. It goes into great details. Yes. Oh, it's great. All right, to make sure. Cool. Thank you, Braun. Creating a policy so that everyone understands what is allowed and reduce misunderstandings and possible conflicts. Absolutely. All right, thank you for your input. I'm going to go ahead and keep moving. All right, so understanding the difference between disease and illness is crucial to providing competent care. Disease is the physiological and psychological processes in the body, where an illness refers to the psychosocial and emotional meaning and experience of the disease that a patient may be having. Oftentimes there's a disconnect when a patient seeks treatment for an illness, but providers are primarily trained to treat a disease. And because of this disconnect, it's important that providers address both disease and illness, and gaining a better understanding of a patient's perception is extremely valuable in doing so. So examples of this may be that there are some cultures who view the onset of Alzheimer's, cancer, hypertension, and diabetes as inevitable during the aging process. Because they think that these are natural, they may not seek treatment. Another patient who may be entering the American health system may believe that a prescription will treat an illness immediately and stop taking any medications that were prescribed when symptoms subside, despite the fact that the disease or illness may not have been treated fully. So on your screen, there are some cultural and social factors that may influence a patient's experience. So these include income, language, religious traditions, family relationships and structures. Various worldviews bring different beliefs about the supernatural world, and that can affect how one understands the cause of illness. Are there any other cultural or social factors, maybe more specific ones that you can think of that may also influence a patient's experience of illness? I'll open the floor again to anyone who would like to either unmute themselves or participate in the chat box. Past experiences with healthcare, absolutely. Thank you, Rebecca. Personal experiences, yes. Seeing treatment fail on a loved one, so losing faith in the healthcare system. Yes, that's a great point, Sierra. Racism and misconceptions, health literacy, absolutely. So health literacy is the ability to understand medical terms and kind of everything that goes into play with care. That will be discussed in a communication session with our brown bag. Internet message boards. What is it? All right. Stephanie, could you elaborate a little more on internet message boards, kind of what you mean by that?
Sure. Sometimes people will get their information from internet message boards where they're purposely seeking out a viewpoint that matches theirs. Things like the anti-vaccine movement get a lot of traction from internet message boards where a friend of a friend had this experience and I'm sharing it, and because it aligns with what that person is already suspecting, being able to find quote unquote evidence on the internet can really entrench those beliefs and those biases.
Absolutely. Yes, that is a great point. Thank you. And with the increase in technology that we are experiencing, and with more and more people having access to these information, that can definitely be a contributing factor. WebMD diagnosis, yes, absolutely. Scaring people into thinking care won't work. Bias confirmation. Family experiences and resulting outcomes. Thank you, Ron. All right, cool. And on this slide, I would also like to touch base about the language portion of it. As I mentioned earlier, because Anchorage has so many spoken languages and Alaska has so many native languages as well, it's very likely that we will be exposed to people who may or may not speak our own language. They may speak English, and if they do, it may be very limited. So having an awareness of the level of comprehension is crucial, and making sure that there are resources there provided, whether it's an interpreter or a translator or materials to support that patient who may have those limited language proficiencies. All right, so it's important to balance one's knowledge on a patient's culture with what you are able to learn from them about their specific health-related concerns. It is a continuing process of learning and building upon one's foundational knowledge. And so taking a knowledge-centered approach, which uses specific information about groups, this can include any history on the group, cultural ideas of illness and disease and how that affects health-seeking behaviors, using health-oriented data and disease patterns from this group. Taking this knowledge and applying it to working with your patients can create a trusting relationship between you and your patient. This can continue to establish rapport and a comfortable setting. And using the knowledge you already have is best paired with a skills-centered approach. And this is important because it's not possible for everyone to know everything about every culture, especially when you're seeing multiple patients. And so using effective communication to continue to ask questions and ask for clarification when they express something to you is crucial to understanding the context of your individual and what they're going through. So this will include a development of self-awareness and allow one to reflect upon their own views and how those interact, or how those affect how you interact with others. So cultural competency and practice, once you use your knowledge, once you have a knowledge base and you continue to grow on that knowledge by asking questions, let's take it a step further to be sensitive to those health beliefs. And once again, balancing knowledge and communication to further clarify and understand your patient. And staying humble and eager to learn. I think this is really important to note, as when a patient feels as though the provider cares and is genuinely interested in where their perspective is coming from, they'll be much more likely to continue to share concerns with you, as well as continue care in the future. All right, one more case study for you. A Chinese immigrant had surgery and was told to force fluids by the nursing staff. The client refused to drink the water from the pitcher left at his bedside and was told if he did not drink, then an IV would be started. The staff decided that the client was uncooperative and non-compliant. The next day, the client's daughter told the nursing staff that her father would drink hot herbal tea, but not water. All right. So this is a great example of how had effective and open communication been used. A provider and patient, or in this scenario, a provider and a family member could have reached a mutual understanding. So does anyone have any thoughts on this specific case study? I can open the floor again, and anyone can pitch in any thoughts. What questions could have been asked? All right, Diana says, I find making a personal connection with the patient helps create that balance. I have learned with my 10 years of being in Alaska that introducing myself and where I am from, who I am, gives them a chance to see who I am as a person and are more likely to open up to me. Absolutely. Yes. Oh, Trina, patient advocates. Yes, so important. Definitely. When working with elder patients or patients with disabilities, definitely having that advocacy. Yes, a smile does go a long way. Absolutely. I know that I feel more comfortable when people are smiling around me. How about why? Great question. Hey, Bron, do you want to kind of elaborate on that? If you're able, no worries. If not, all right. Oh, can be applicable to those individuals suffering from a mental illness as well. Yes, absolutely. Yes, was he offered anything other than water? This is from Rebecca. Was family approach for ideas or suggestions? Yes, so asking those questions, making sure that if it was recognized that he wasn't drinking tea, or excuse me, that he wasn't drinking water, asking questions as to what an appropriate solution might be. Yep, okay, do some probing to find out why they didn't want to drink the water. Yes, okay, I see, Bron, what your question was there. Then adjust. Yes, yes, absolutely. A good question. Is there a change of patient's chart to easily add this information? Yes, that's a great point. Documenting, continuing to make documents up to date so that providers in the future can have information on this patient as well. That's a great point. Then I see from Janie, a similar situation occurred at an inpatient behavioral health hospital, BH hospital, where a rural patient was refusing to eat and was deemed non-compliant. What the issues was the patient was not familiar with the American cafeteria options and wanted rural subsistence foods. Yes, okay, that's a great similar scenario to this one. Mary Lou, the nursing staff could have asked if there was anything else they would like to drink. Yes, great. Mari, the RN, assumed he was being uncooperative. She could have asked the patient and family what would help him drink. Oh, no worries, Bron. Sorry, I just got to your last comment, but thank you. I appreciate your input. Go ahead and.
Are you able to hear me?
I heard someone who spoke up. What was your name?
My name's Diana.
Hi, Diana. Yes, we can hear you.
Do you mind if I tell a quick story about a situation like this and how it is important to actually speak with your patients and get to know them?
Yes, please do.
So I've been a nurse now for, gosh, over 12 years now, which I can't believe. And I have, when I came here, I originally from Maine, started as a nurse in New Hampshire, and then moved out here to Alaska a decade ago. And one of the patients I have that sticks in my mind, and I've done this story a couple times for nurses talks, is that I'd come into the shift, it was an overnight shift, and I get a report that I have this guy who is absolutely non-compliant. He's been non-compliant several times and has left the hospital. And I'm like, oh, in my head, I'm kind of like, oh, great, this is going to be a fun night. And I go into his room and what I see is this guy who is huge. I mean, he is like easily doesn't fit the bed. He's 6'5". He's just this huge guy. Not fat by any means, but just enormous physically. So I get talking to him and he's very gruff, and he'd had to have some esophageal varices repaired, which is why he was there overnight. So I was talking to him and he starts swearing at me, and I was like, sir, this really isn't appropriate. And he's like, and I look at his table and he has just this small little dish and it's empty. I'm like, so what did you have to eat? He's like, I didn't have food. He's like, that's what I want. And then I kind of start going, oh, I'm like, sir, when was the last time you ate? Because I noticed he had orders that he could start on liquids and then move to soft foods if those were fine. And long story short, all he'd had that day was broth. He was starving, which made him then hangry. So he was just starting to get mad, and he started talking about like what he wanted to eat. He basically wanted to eat French fries and he wanted steak, which I understand. Huge person. He wanted some food. So I started talking to him about why he couldn't have those. And when I was doing that, he got really quiet and he was like, you mean I'll never be able to eat those foods again? And then when I realized that he'd had no education as to what esophageal varices was, why he needed to start with liquids and then soft foods and then go on from there. So I ended up doing a long education for him and ordered him as much soft food as he wanted. I mean, he literally, I think, must have eaten a couple of pounds of mashed potatoes. I have no idea. But he ended up staying the night and he ended up getting better. But it ended up being that it wasn't that he was being non-compliant. It was that he never had the education as to why he needed to do forward. There wasn't a cultural barrier except for that, he had moved to Alaska, chose to live in areas that were not populated, didn't have a whole lot of contact with people. So, and it was just a matter of taking that time to get to know him, understand him, not be afraid of his size and his gruffness and his language. And by the morning time, I mean, he was basically a kitten. He was well fed. He understood why he was there. He understood that he'd be able to have the foods that he liked, that he felt were fulfilling to him down the road. And I've had many interactions with patients like that, whether it's a cultural thing or just an understanding of why they're there. I find that gets missed quite a bit.
Yes, absolutely. You pose a really awesome point with education, and when patients are not educated from the beginning, you made a great point. The fact that he was staying there for a little while and having exposure to other providers and other nurses. If that education wasn't there in the beginning, that can definitely cause tension with future providers as well. Yes, thank you, Diana. That's a great story. I also saw from Teresa, sometimes the providers don't explain the why of requests. So yes, definitely going into the education piece of it. And sometimes once a patient knows why they are being asked to do something, they are much more compliant. Yes. All right. Awesome. Thank you so much for everyone, for everyone's responses. And thank you, Diana. All right. So providing a patient-centered approach is crucial to providing culturally competent care. And this focuses on the concept of working closely and directly with your patients to continue to learn about the influences that their cultural and social realities face. So some of these approaches include treating all patients with dignity and respect, providing unbiased information to all patients and all families, strengthening a patient's sense of control. And these principles should be applied to all patients, which will empower individuals to be an active partner in their own healthcare. When patients feel like they are an active partner, they're much more willing and comfortable with going forward with care plans and opening up about their concerns and questions. Very often assumptions are made about cultural groups that are based on limited information. This is similar to the essentialism contributing factor that I discussed earlier and can negatively affect patients' care. Remembering that every encounter is a cross-cultural encounter, especially in healthcare. It happens in our personal lives as well. Because we all identify with multiple cultural groups simultaneously, that those are changing and shifting as we grow as individuals, and therefore those values will be changing as well. So understanding that everyone is bringing something different to the table in terms of viewpoint. And finally, never assume that patients who look like you share your beliefs, values, and practices. Sorry there. All right. So complementary and alternative medicine, these are systems and practices. Some are products that may not be considered part of conventional or Western medicine. So complementary medicine is used in conjunction with conventional medicine. An example of this would be a patient who is seeing a primary care provider as well as an acupuncturist. On the other side, an alternative medicine is used completely in place of conventional medicine. So a patient or an individual may not be seeing a primary care provider, but maybe only seeing an acupuncturist. And recognizing that there are alternative sources to healing and looking at a patient as a whole is very helpful, because using a combination of conventional and Western medicine and a patient's cultural traditions will create a positive foundation for care and the patient-provider relationship. Patients will have a higher satisfaction of care and be much more comfortable with the treatment plans put in place. So this slide just provides a few guidelines to addressing traditional beliefs in a culturally sensitive manner. Once again, becoming aware of the commonly held medical beliefs and behaviors, and applying that awareness to assessing the likelihood of a patient or family member acting on these beliefs either during an episode of the specific illness or during a time that someone is experiencing a symptom. And finally, bridging the gap and arriving at a way to successfully communicate between the two belief systems, and allowing that common ground to be met. An example of alternative or complementary medicine is cupping. This is a practice that dates back to ancient Egypt, China, and the Middle East, and is becoming increasingly popular in the Western societies and cultures. It takes place with a series of small heated glasses that are placed on the skin, and it kind of acts as a suction cup and pulls your skin upward. It's used for many purposes, including reducing pain and inflammation. Others use it as a form of deep tissue massage and relaxation. And many cultures believe that it draws out bad forces and spirits to restore balance. One unique thing about cupping is it does leave red marks on the body that look very similar to bruising. And it's funny, my mom is a 4th grade teacher, and she had a student who came to school one day with cupping marks on his body, and because his parents were practitioners and provided cupping for their child, and she was very concerned. She had no idea that cupping was a common practice or was becoming increasingly popular, and called the parents to just to make sure everything was okay, because she did not realize that it was a form of healing for the child instead of abuse. So that wraps up our cultural competency for today. And I just want to stress that being aware and sensitive of cultural differences among patients will greatly improve overall quality of care. It will foster healthy relationships in the future, and providing for a diverse community is extremely important, especially in Alaska and our day and age. So thank you all for everything that you do to support our diverse communities, especially during this challenging time. I know that we've all been faced with so many changes, and your support for your patients is so appreciated. So thank you for participating. We hope to see you back. We'll start again with another topic on Monday next week. I will go ahead and hang out for a few minutes. Feel free to log off if you are ready to go. If you'd like to chat a little bit more, I will be around. So thank you, everyone.